PTSD is an invisible monster. It disguises reality. When I was sucked into what I learned to call the trauma vortex, I often couldn't distinguish between what was real and what wasn't. I thought I was going crazy. PTSD told me over and over again, you're not safe, you never will be, being dead would be better than living one more day like this. The message from my illness was clear, give up. Even though I had sought help from well-meaning doctors and therapists for years, my PTSD and trauma were continually missed and dismissed. It wasn't until I visited Dr. Google with the words exaggerated startle response that I came to learn the truth. I wasn't losing my mind. I was struggling with a real problem that had an actual name. Indeed, in light of the fact that PTSD is a brain injury, the flashbacks, nightmares, rage, and utter despair actually made sense. And this is actually an article I wrote. My name is Jenny Schaeffer. I'm one of the speakers today. I'm a national recovery advocate with the Eating Recovery Center and an author. I want to close right now by sharing how the article closes, which is good news. Actually, out of unbearable pain and suffering, people can recover from PTSD. And throughout this talk, I'll be sharing some of my personal story with PTSD and that healing really is possible. And we want to thank you guys all for joining. It is because of people like you who are devoted to mental health care that I actually got better. So I want to give a shout out to all those who are joining and introduce you guys to my awesome co-presenter, Dr. Andy Stone.
Thank you, Jenny, and hi, everyone. I just want to say, Jenny, thank you so much for writing this article. It's really helped increase my empathy and insight and understanding into working with individuals who have PTSD. So thank you. It's really made me a more empathic clinician. Just a little bit about me. I am Andy Stone. I'm the director of the Mood and Anxiety Program at Insight Behavioral Health Centers in partnership with ERC. Before I start, Jenny and I wanted to get a sense of how many of you use DBT in your work. Oh, cool. Starting to see some hand raising. Yeah, wonderful. And also, let's see. Well, the next question is, I'm sure you guys aren't surprised by this, how many of you are trained in doing prolonged exposure? One hand raised. Okay.
Looks like we have more people who know DBT and less prolonged exposure. So you guys are in the right place because that's what we're going to talk about.
Exactly. So I'm going to get us started and wanted to start off by explaining to all of you why my colleague Laura and I, who's the Senior Director of the Mood and Anxiety Program, chose to get formal training in this new protocol called DBT Prolonged Exposure. Melanie Harned developed DBT Prolonged Exposure, and we'll talk about that as we go. What we have found as we've done follow-up studies and research at our center is that around 80% of our clients have trauma, while not all of them have a PTSD diagnosis. A significant portion of them do. Not surprisingly, the research shows 66% of individuals with PTSD have 2 or more comorbid disorders, including eating disorders, personality disorders, and up to 30% attempt suicide. So though DBT has a high success rate for treating borderline personality disorder and other high-risk comorbidities associated with PTSD, it is not sufficient in and of itself in directly addressing and treating PTSD. Rather, it does a really good job in minimizing the disabling symptoms. So this led Melanie Harned, who was a postdoc of Marshall Linehan's. Goodness, I'm not exactly sure when she started, but she did research for over a course of 10 years to design a protocol that integrates PE, prolonged exposure, within DBT. The unfortunate reality is that this high-risk population, this is a population that we tend to treat here, clearly our clients with PTSD and these high-risk comorbidities, are often excluded from participating in research trials for prolonged exposure and other evidence-based treatments for PTSD, likely due to the myths associated with treating these clients, the myth that they can't stay safe during PTSD treatment. So this led Melanie to spend about 10 years designing, conducting research on the efficacy of her DBT protocol, which is designed to treat both PTSD and its associated complex comorbidities. So I'm going to get back into my script. And I'm going to let Jenny take it away.
Thank you, Andy. So for you guys who are joining us today, and if you're going to join us, by the way, this is a 3-part series, so please check in for the next 2. I'm actually going to be the live case study for the webinar, so I'm excited to get to do that. So in order for you guys to kind of understand my story as we go through the webinar, we thought it'd be helpful to really just kind of give an overview quickly of kind of my development of post-traumatic stress disorder. So starts at the very beginning of the story, which was when I was born. And unfortunately, I struggled with birth trauma. And the reason that's important to note here is many of you guys probably know that people with multiple traumas actually tend to be more vulnerable to developing post-traumatic stress disorder than maybe people who just had one trauma in their life. So that's significant in that way. And what's really important too on this timeline is that that second little dot, anxiety. So I want to kind of spend a bit of time with that and kind of explain. I was born into this world a highly, highly emotionally sensitive person, and if you know me, you know that to be true. So my parents noticed this at a very young age. In fact, they said at 3 years old, I would get so anxious about just things that didn't matter, little things, just so highly sensitive, that I would actually cry so hard that I would make myself throw up. At 3 and 4 years old, throwing up from high anxiety. So that just gives you a picture of the level of anxiety that I struggled with. And no surprise for many of you that I also ended up struggling with OCD as a child as well. I kind of was an obsessive toothbrusher. I would brush my teeth just constantly, and my dentist thought it was great, but of course it wasn't. It was a disorder, and so I needed help for that. And also that kind of morphed for me into perfectionism. So the reason that's all important to say is I was definitely not a person who, once I developed PTSD, that was just kind of the first mental disorder in my life. So the DBT protocol was especially created for people who struggle with more than one mental disorder. So as you can see from my timeline, I wasn't someone who, just had a car wreck when I was 20 and then went to a therapy for the first time in my life. And the reason I mentioned that example is Andy and I were just at a conference last week, and we saw a case study about someone who had gotten in a car wreck when they were 20 years old, and then they had PTSD from it. It was very debilitating. But this was the first time this person had ever been to therapy. And so, again, this was not my case. So you can see that early on I had some comorbid issues that were happening. And gratefully, because of people like you, I've learned how to shift some of those to positives. But unfortunately, I didn't know that at 4 years old, 5 years old, 6 years old, as I was growing up. So many of you know me for my books on eating disorders. So the third dot there, you see eating disorder developed. And I'm sure you're not surprised if you guys are experts in eating disorders that high anxiety and perfectionism, OCD, can definitely fuel an eating disorder. So I've developed an eating disorder full-blown in college. I would have been diagnosed with anorexia, binge purge type, had I been diagnosed, but unfortunately diagnoses tend to be missed and dismissed a lot in my life and also in many people I know, which is why we love doing these webinars. But and what's interesting is the trauma in my life actually happened after my eating disorder. And later on we're going to talk about the reverse a bit. So many of your clients might have had trauma and then later developed an eating disorder. But as you can see in my case, I actually had an eating disorder first. And between the eating disorder and my trauma was actually about 5 years of eating disorder treatment. So I finally got help, finally got a diagnosis, and actually saw really great professionals who absolutely knew what they were doing. But as you know, an eating disorder doesn't just cure itself quickly. And so 5 years into my eating disorder recovery, I was not fully recovered, but I had some good tools. So my trauma happened, again, about 5 years after I got help for my eating disorder. And what that was, and the only reason I can talk about it now, is because of prolonged exposure therapy for PTSD. I actually was raped by a boyfriend of mine. And I can say that now so simply because I spent so many hours in prolonged exposure therapy doing exposures around that very incident. And we'll get on talking more about prolonged exposure and the types of exposures that you can do for someone who's experienced sexual trauma in the second part of the series. So again, please sign up for that. But so I'm very grateful for prolonged exposure for me being able to even talk to you guys today. And part of the prolonged exposure DBT protocol is actually living an exposure-based life. So I have to thank you guys again for letting me talk, because just doing this webinar is living an exposure-based life. But after my trauma occurred, I'm sure there's no surprise that you see the eating disorder and PTSD are kind of existing together. And what that really looked like was a lot of binging and purging. And you'll notice there in the stat underneath the arrow is that we tend to see eating disorders and bulimic symptom eating disorders more often than, say, restricting type anorexia. And we'll get into that. I'll get into that a little bit more later. But so it's significant to note that my PTSD and eating disorder did coexist for a little while. Another piece that, for those of you who treat eating disorders, that's interesting and relates to PTSD is you'll see down at the bottom of the slide it says anorexia nervosa. There's a propensity to extreme fear conditioning and greater than normal resistance to extinction. That's Dr. Michael Strober's study. So what that really means is people who are prone to developing anorexia nervosa, so not necessarily people with anorexia nervosa, but those who are vulnerable, basically the fear circuitry in our brains is turned up. So in a way, I was kind of born into this world, a highly emotionally sensitive with fear circuitry turned up, which again, that made me more vulnerable to developing PTSD. If you add fear onto someone who's already fearful, it can obviously makes someone more vulnerable to PTSD. And something interesting I learned from our co-presenter who you'll meet next time, Laura, is that people with eating disorders actually tend to be more predisposed to phobias, which in my life I know that's true. And again, I think that made me more susceptible to PTSD. So you're kind of seeing how the eating disorder and PTSD had an interplay in my life. Good news is that I was able to move into full eating disorder recovery. I think I owe that to three things. One is I finally got help for post-traumatic stress disorder symptoms. And I say that because I didn't know I had PTSD at the time. You see it on the timeline there because now I know that I had it. But I didn't really know I had PTSD for about 10 years after my trauma happened. Sadly, the average amount of time from the onset of PTSD symptoms to a diagnosis is about 12 years. One of the big reasons I'm passionate about doing this webinar series is that we just really want to get the word out about PTSD. Why did it take 10 years for me to get a diagnosis? And as you saw in my article, it was actually Dr. Google that diagnosed me. And what happened there was I entered exaggerated startle response into the search engine and found PTSD. But when I saw EMDR, I was actually really working on the startle response, the symptom of PTSD. Didn't know it was PTSD, but knew it was startle. Good news is EMDR is an evidence-based treatment for PTSD, and it worked. It helped a lot with the startle response and some of those initial symptoms of PTSD. So that was one key that happened that pushed me into full eating disorder recovery. Second key was broke up with the guy. So, I was no longer exposing myself to being traumatized over and over again. And third key was I actually wrote my book, Life Without Ed, and that was really a big step in accountability. And because I did that, and I had been in eating disorder treatment for many, many years, I was really able to kind of solidify things and move into full eating disorder recovery and really believe that's totally possible, full recovery, and we believe that fully at ERC. But the key to that piece is if you look just above the full eating disorder recovery, there's the PTSD avoidance. So what does that mean? That just means I didn't get into relationships with men. I avoided intimacy. As long as I avoided intimacy, I was great. I was happy. And you'll see that in my second book, Goodbye to Hello Me. And it's interesting to me now when I look at that book, I talk a lot about how I struggled dating. I talk about going to dating therapy. But really what that was I needed to be going to PTSD therapy. And it wasn't until the book was published and out for many years that I actually looked back at it and went, oh my goodness, I actually had PTSD, but I was just in avoidance mode, so I didn't really know it. It just cropped up when I would start dating someone. My friends used to joke that I was so good at breaking up with people because I would often feel like when I was dating someone that I was going to die. And I would tell the guy when I broke up with him, I don't know why, I just can't do this anymore. I feel like I'm going to die. And later on you'll see that was one of my PTSD symptoms, is just this hypervigilance. I'm going to die. So I was able to exist in full recovery and actually be pretty happy as long as I avoided dating, which clearly is not a full life. So more work was to be done. But you'll see that PTSD eventually did emerge in my life. And it came into full-blown when unfortunately, it was when I got engaged and then married. So I was no longer avoiding intimacy, right? So unfortunately, that's when PTSD really reared its ugly head full-blown in my life. And Andy's going to actually pull us into the DSM criteria to explain some of what the symptoms look like from a clinical perspective. So take it away, Andy.
Okay. Thank you, Jenny. Jenny and I will talk about PTSD together. What I want to focus on is, I'm assuming to many of you, you know the DSM-5 criteria and how DSM-5, PTSD is no longer an anxiety disorder, but a trauma and stressor-related disorder. A line that Jenny came up with that I wanted to share is, PTSD is as real as a broken leg. The brain is injured, though, so we can't see it. We all know patients with PTSD have so much difficulty being present in their own lives. So as we go through, there's the 4 categories of PTSD symptoms, and for time's sake, I'm just going to, highlight, so we have the re-experiencing symptoms, the avoidance symptoms, the increased arousal symptoms, and the negative alterations in cognitions and mood. And Jenny, I'm hoping you can come in and bring some of these clinical symptoms to light.
Yeah, so I like to explain that for me, when I developed full-blown PTSD, it was really like I put PTSD glasses on. So all of a sudden, I was looking at the world really with this lens of negativity, this lens of fear. I was seeing the world not as it really is, but kind of as my amygdala sees it, which thought I was always under threat. So that led to a startle response that developed again. That led to so much depression. Just really everything was negative. That's the key there. Something I struggled with a lot was the re-experiencing symptoms too, which for me came in as nightmares. That was one piece. But also it came as these flashbacks that were really confusing to me. I remember, for instance, coming out of my back door one day and my husband was coming the other way. And we lived together. He was my husband, and he was actually a nice guy who was not going to hurt me. And when my body saw him, it actually fell to the ground and kind of in a duck and cover, like I covered my neck as if he was about to attack me. He was not about to attack me. This is what I wrote the article for. I really thought I was going crazy. Why am I falling to the ground? Because this nice guy is walking out of, he's near my house, because it's our house, because we're married and we live together. But for me, it was like he was a tiger. And I still struggled with avoidance. I used to go off and kind of stay in hotels some nights just to get away so I could kind of feel this calmness. I also struggled with dissociation, which some people with PTSD struggle with, and not all. But that was a piece for me that was really scary. And sometimes that involved rage. I remember being dissociated a lot when I would be raging. In fact, sometimes I would even see myself yelling at my husband. And again, I felt like I was going crazy, because how can I see myself yelling at my husband? It's like I'm not in my own body. So all those symptoms were just really confusing to me. And when I finally got the diagnosis, it was like, wow, light bulb came on. Other people have this too. People can get better. So, yeah, Andy, thank you. Go take it back to you. Prevalent.
Yeah, no, thank you, Jenny. And again, like, your bravery and courage in sharing your story and sharing with us what it's really like to have PTSD is just, again, I can't thank you enough for your bravery.
Aww.
It's really, again, increased my ability to be effective with this population. Prevalence, I think, will, just so you all can see the statistic, I don't think probably anything in this slide would be particularly surprising. What I would like to move to the next slide, common complex comorbidities. Who would like to say that 10 times? So, like I said in my introduction, 66% of individuals with PTSD have 2 or more comorbid disorders, including substance abuse, personality disorders. Of this group of patients, 30% attempt suicide. We are particularly interested in this group of patients because this is the patients that we in the Mood and Anxiety program in higher level of care tend to treat. And Jenny, I think you're going to talk a bit about high comorbidity with bulimic symptom eating disorders and PTSD, right?
Yeah. So I mentioned that before, and I want to give a shout out to my friend, Dr. Tim Brereton. He's actually my mentor in eating disorders and PTSD and comorbidity. But what a lot of his research and writing has shown is what we talked about. We tend to see PTSD more in bulimic symptom eating disorders. We don't know why. Evidence shows that maybe it's that restricting is not as effective strategy for numbing emotions as binging and purging is. But what I wanted to point out here is from my timeline, you saw that I experienced trauma after my eating disorder. Well, oftentimes it's PTSD that mediates the eating disorder. And what Dr. Burden has taught me and what the studies show is that for many people, someone will develop trauma and then they might develop PTSD as a result of the trauma, and then it's the PTSD that mediates the eating disorder developing. So in other words, someone with trauma doesn't necessarily develop an eating disorder unless they develop PTSD as the mediator between the two. So that's just something I wanted to point out that is the case for some people, and not my case, but for many people.
Okay. So I'm going to talk a bit more about the high comorbidity with borderline personality disorder and PTSD. Maybe we could do another hand raise. I am curious, how many of you work with patients who are diagnosed with borderline personality disorder? Oh boy. Yeah, seeing some hand raising. So it's not surprising there's a high comorbidity. 30 to 50% of clients with borderline personality disorder also meet criteria for PTSD. I'm assuming you all could relate, when I work with clients with borderline personality disorder can often be scary, frustrating, confusing. The work of Sherry Manning, her work has really increased my capacity for empathy and understanding while working with these population, as well as a desire and a willingness to take them on as patients. So what does it feel like to have borderline personality disorder? So for individuals with this disorder, it can feel like drinking a cup of boiling coffee, while others experience it as lukewarm. Where we feel slight irritation, a patient with BPD feels rage, or we feel some attraction to another person, a person with BPD feels unbelievable desire. According to Manning, BPD patients with this have fast emotions, so they get quickly stirred up and very unpredictable. They change in a blink of an eye. To understand emotional sensitivity, think of a person with BPD as being raw. She goes on to say, his emotional nerve endings are exposed, and so he is acutely affected by anything emotional. Her work has really, again, increased my empathy, and it also makes sense why many treatment providers like myself have shied away from working with individuals diagnosed with this disorder, and why there are myths that exist about treating high-risk comorbidities like BPD and PTSD. And looking at the slides, the myths are patients' PTSD can't be treated because it's unsafe to do so. Patients will harm themselves and lose behavioral control. Essentially, they're too high risk to have PTSD treatment. And patients don't want to treat their PTSD because they can't tolerate the distress. The truth is, and the research does show, that if patients are given a preference for the type of treatment they can have, their outcomes improve. So often the research shows that it's the therapist, maybe lack of education, myths that they have that get in the way of patients getting the treatment for PTSD that they need. These myths have resulted in about 30% of patients referred for clinical trials for PTSD research being excluded from these studies. Melanie Hardet also found routinely clinicians who use standard trauma treatments like prolonged exposure use even broader exclusionary criteria when deciding to use this treatment with their clients.
If you see the little bamboo in the corner, that's actually a sign that I'm supposed to talk, and we'll tell you what the bamboo stands for at the end. So just to kind of encourage you to stay till the very end. It's an exciting bamboo story. But what I wanted to share here just really briefly is I just love what you said, Andy, and it's so true. I actually really wanted to treat my PTSD once I realized what was happening. In fact, I bought that book that you're looking at. Dr. David Barlow has a series called Treatments That Work. This is actually the prolonged exposure protocol workbook for the patient. So there's actually a protocol for the clinician, and then this workbook I bought myself. I got it on Amazon, and actually was searching fearlessly like for some provider in Austin, Texas to treat me, and it was so hard to find anybody in the whole city of Austin who knew what prolonged exposure was. And I did find someone, and so I actually started outpatient therapy, and I was begging him to do PE. So, the truth is that PTSD treatment, especially, exposure-based, can be really scary, but my life with PTSD was way scarier than the treatment ever was. So I was desperate to get better. And the good news is I never once relapsed into my eating disorder throughout a long period of my prolonged exposure therapy actually was very prolonged, which isn't normally the case so much, but I never relapsed into my eating disorder. And so that's kind of the hopeful side of it all.
That is so true. PTSD does not improve until you target it. Where on the slide is high risk, too risky for PTSD treatment, and I'll just briefly summarize this. The researchers analyzed 18 randomized controlled trials of prolonged exposure and assessing the common comorbid conditions. The research indicates that the comorbid disorders and additional symptomatic features either decline along with PTSD symptoms or do not change as a result to PE. No exacerbation of symptoms. Of course, the problem is there's inconclusive and insufficient evidence due to the fact that the exclusionary criteria for this study excluded people with substance abuse, personality disorders, psychosis, and dissociation, and I'm assuming suicidality. So this is, again, fueled Melanie's research and her pursuit of finding a treatment that could treat both high-risk comorbidities and PTSD. How many of you don't have to raise your hand, but you can if you want to, know who this woman is? If I could go out to lunch with anybody tomorrow, it may be her. Don't tell my children that. Yay, hand raise. It would be fun. Okay, so thank goodness for DBT. I don't know how many of you out there drink the DBT Kool-Aid, but I certainly do. What I want to do is a quick background on DBT, and I don't know if...
This is Marsha Linehan, too. We didn't review...
Oh, my gosh, I didn't say that, did I?
It's Marsha Linehan, founder of DBT, everybody. So,
thank you so much, Jenny. Yes, I got so excited. I just wanted to go right in there.
You were already having lunch with her.
I know. I was already having lunch with her, exactly. Okay, so Marsha, or DBT, evolved from her. She was having problems applying standard CBT treatment to severe and chronically suicidal patients, meeting criteria for borderline personality disorder. Marsha thought that her borderline patients needed more in addition to the change-based approach like CBT. So she added acceptance strategies to change-based treatment and mindfulness strategies given her own practice with Zen Buddhism. She also borrowed principles of dialectics to guide treatment decisions. Another hallmark of borderline personality, of dialectical behavior therapy is you can treat multiple targets, multiple behaviors at the same time, and the hierarchy of targets that we're going to go into in a little bit grounds us, so we as a therapist know where we are headed, but the client knows too. You and your client are headed together, and the client is aware, so it's like you have a reciprocal relationship. Dialectical behavior therapy, it looks like, I think, given I maybe will pass over this slide because I'm going to talk about most of this as we go on. We're going to talk about the biosocial theory. We're going to talk a little bit about dialectics. And probably many of us know DBT falls in the third wave CBT treatments, dealing with not only what we think, but how we think. The research shows DBT has shown to be effective in reducing suicidal behavior, hospitalization, treatment dropout, and improving interpersonal functioning and anger management. DBT is one of the only few empirically supported therapies for clients who present with multiple problems, such as BPD, suicidality, and has a very strong research base, and it targets a wide range of problems that overlap with PTSD and most conceptualizations of complex PTSD. The biosocial theory of dialectical behavior therapy, we just taught this theory in our DBT group. Clients really appreciate this theory. I would encourage you, all of you who do DBT, this would be a great slide, or just to teach them the biosocial theory. It was originally developed to understand the development and maintenance of borderline personality disorder. And what I really want to stress with this model is that it's taught to patients very early on in treatment. It validates what they can't control, and it validates what they can control. So they can't control nature. They can't necessarily control their genetic predisposition to maybe developing PTSD. They certainly can't control, let's say, their social support as a child or their parents' mental health. So what they can control is how their regulation, how they cope in their environment. Only, though I should say the caveat is they can only control regulation when they learn the skills to be able to control regulation. So we all know DBT teaches skills, and I'm going to get back to that in a little bit. While we're on this slide, I want to just take, dialectics. So yeah, we could spend a whole day talking about, dialectics, dialectical philosophy. She borrowed concepts of dialectical philosophy from Hegel. And two things I just want to say about dialectics, because this will be important later on. Dialectics assumes that no one has a corner on an absolute truth, but that doesn't mean that there isn't a truth. This can also be a dialectic. Dialectics refers to finding a balance or a middle path between two different ideas. We can talk about dialectical theory if you all would like to later on. DBT is both a principle-driven and a protocol-driven therapy, and I'll talk about the importance of both of that. Principle-driven, so we're in DBT, we're looking to decrease cognitive dysregulation, impulsiveness, emotional lability, labile moods, interpersonal chaos, right? These are the specific goals of DBT. The skills, training, assumptions. You can't talk about DBT without talking about the assumptions. And rather than read these, I just want to stress that skills are taught to patients so that their ineffective behaviors no longer are solutions to their pain. Skills are going to replace these behaviors. Oftentimes we talk about clients are not motivated. Well, according to these assumptions, the assumption is people want to improve, so implicitly they are motivated. They just need to do it differently. They need to try differently. Self-motivation requires skills. Clients come to us because they want to feel better. They want to feel better now because they're miserable. DBT, what we have to teach them, takes a lot of effort that they don't think they have in the moment, but it takes more effort living in misery. This can be a very difficult group when we go over the assumptions. We are on the modules, and what I want to go back to is the most fundamental dialectic in DBT is the necessity of accepting patients just as they are within a context of trying to teach them to change. This dialect influenced Marcia to create both change-based skill modules and acceptance skill modules. So as we see the first slide, we have our acceptance-based modules, mindfulness, and distress tolerance. There's so much that we could talk about mindfulness, right? I'm sure a lot of you teach mindfulness, practice it. The important concept I want to just emphasize, mindfulness helps us increase control of our mind, right? It builds pauses in our lives, in the lives of our clients. We teach them how to participate in life, how to throw themselves in without self-consciousness. Our brains are constantly manufacturing thoughts and living in the past that is already over or in the future that hasn't happened. So mindfulness allows us to stay in the present. And we also have to accept the fact that our minds are meant to wonder, and we can, with effort, bring them back to the present. So, distress tolerance. This is a unit where we are teaching skills to help clients accept what they can't change, what they can't fix, what they can't manipulate, what they can't avoid. Learning how to feel better, not necessarily feeling better. Really, truly seeing reality as it is. Distress tolerance skills, acceptance principles can be so difficult for our patients who've experienced trauma. They try to avoid their pain. They try to dodge their pain. They learn that they can't do this. Trauma victims have lost a belief in their inherent wisdom, so we have to teach them to believe in themselves again. Emotion regulation and interpersonal effectiveness, those are the next two modules that are the change-based modules. We spend a lot of time on emotion regulation. So many of our patients can't even identify an emotion, how they're feeling, or they're feeling too intensely. We're teaching them how to regulate those emotions, like if I were really cold right now, I'd put a coat on. If I were really hot, I would take my scarf off. That's the way that we teach them how to regulate with the skills. And an important part in emotion regulation is that we're teaching them how to build positive experiences and even joy into their lives, as so many of them assume threat based on their histories. Interpersonal effectiveness is the last change module, and I think that it's pretty self-explanatory, but I think it's very relevant to our patients with trauma, how to let go of hopeless relationships, asking for what they need, saying no. I'm going to pause for Jenny.
Thank you. Yeah, so a little bit more on my story. So I mentioned that I found a provider in Austin. I was doing outpatient prolonged exposure therapy, and I did allude to the fact that I was kind of a slow learner on things. So there's many reasons why, and that's probably a whole nother talk, but the prolonged exposure wasn't working in outpatient therapy, so actually I needed to move to a higher level of care. So I looked for a program that actually utilized prolonged exposure, and I found a partial hospital program that actually had a PTSD specific program with prolonged exposure. And I went to that program, and this is the only piece where I want to say, Andy, I wish I would have known about Insight, because I really needed to go to Insight back then. Andy runs our Insight program, which is our mood anxiety program. And I just didn't know about Insight back then. But needless to say, I did find a program. And the reason it's on this slide with DBT is the program was very DBT informed. So the prolonged exposure DBT protocol had not been, it wasn't available at this time. So Melanie Harnon was not out fully talking about the DBTP protocol. So the program did not utilize the protocol because it did not exist. But we were DBT informed, so I found all of these modules really helpful except the distress tolerance piece. And the reason I didn't find that helpful is because I actually didn't learn it. So the program was very fearful that if they taught patients distress tolerance skills, that we would use those skills in prolonged exposure. So in exposures, and you're not supposed to use distress tolerance skills specifically in exposures. And so they just didn't teach us any of the distress tolerance skills. Now, looking back, I can see that for me, I think was a struggle. I know it was. In fact, I got really dysregulated in treatment and ended up having to take a week off kind of and go to the psych hospital next door and take a break from the PHP partial hospitalization program and actually kind of reset in an inpatient setting. And again, this is why I say, Andy, I wish I would have gone to you because we have residential in Chicago. But needless to say, I did find a program that did PE, and we were DBT informed, but we didn't learn distress tolerance skills. And I think I kind of think, looking back, that probably would have been helpful to learn. I might have saved myself a trip to the psych hospital, but regardless, I got better anyway. But this is all just a shout out for, research and new treatment methods, and what's available now wasn't back then. So I will pass it on to you. I love this slide, Andy, that you created. Where do you begin? Because that is how I felt when I was starting PTSD treatment. I mean, all of this is really perfect.
And it's interesting, Jenny, because that's, as a clinician, I so identify with this slide. and I'm, assuming many of you out there do as well. Where do you begin? Given how much, misery and pain your clients are coming in with. Well, the good news is Marsha Linehan gives us a protocol. She helps us figure out where to begin. Marsha said an ever-changing clinical presentation together with frequent crises resulted in confused therapists and a chaotic therapy. So she provided a dialectical balance between using a generalized protocol-based agenda and an individualized target-based agenda. If you take home anything, I want you to take home this slide. This really keeps us focused in how to begin. So pre-treatment is a stage in the DBT stages of change. Pre-treatment, you're agreeing on the goals, you're establishing a therapeutic relationship, and most importantly, you're educating the client that commitment is not a thought, it's not an emotion, it's not a feeling, it's a choice. So I guess it means it's a behavior. Choosing is a behavior. Stage 1, stabilization. So this is where we're stabilizing our patient's mood, target behavior. So a target behavior, for those of you that don't know the DBT language, is a behavior that the patient identifies as needing to change. Yes, we therapists can identify many behaviors that they're engaging in that need to be changed, but the patient has to be willing to change his or their behavior. So we're stabilizing mood, target behaviors, preparing them with the skills necessary to stop or significantly decrease behavioral discontrol. And we do this by organizing our hierarchy of targets. So we're always starting with decreasing suicidal, life-threatening behaviors. If our client is not alive, we can't help them. We're decreasing therapy-interfering behaviors. Maybe a patient isn't coming to treatment, so we can't help them. Decreasing quality of life interfering behaviors. Maybe they're avoiding their emotions. That so often accompanies people with PTSD. And we're increasing their skills, increasing their behavioral skills, so they're attending skills groups in stage 1. So we're building the self-motivation, we're helping educating, and we're helping clients learn how to generalize their skills to outside of the therapy setting. This all happens in stage 1, and we're increasing the behavioral skills and skills needed to tolerate trauma and PTSD-focused treatment. So in stage 1, according to DBT and Marsha Linehan, there's no processing of the trauma happening. We're just focusing on increasing their skills to tolerate the processing, excuse me, that only happens when they enter stage 2. Stage 2 we're going to talk much more about in the next 2 webinar series, but this is where they're learning, where they're continuing their journey on emotional experiencing, and they're able to experience intense emotions and high distress without escaping. So this is where we're reducing post-traumatic stress, and this is where a clinician would be incorporating formal-based exposure treatment and also informal exposures. We're reducing the stigma of trauma. We're helping our clients accept the facts of trauma. We're reducing self-invalidation, self-blame. I'm not going to spend that much time on stage 3 and stage 4. After PTSD is in remission or the symptoms are not impacting them significantly, moving on to stage 3. And I really like looking at stage 4. I don't think as a clinician I tend to get to stage 4 that much with my clients just because I'm in a higher level of care and we provide short-term treatment. But I really like this idea of teaching them how to have the capacity for joy. Again, they're not leaving treatment necessarily feeling joyful, but they know how to experience joy.
You said commitment is a choice, choosing is a behavior. Isn't that what you said? Earlier on.
Yes.
Anyway, I love that. I think that's so important. Commitment is a choice, choosing is a behavior. That's something I learned too. So if someone was asking about that, I just wanted to bring it up.
Yes. Commitment is a choice. It's a behavior. It's not a thought. It's not a feeling. It's not an emotion.
Yeah, that's awesome.
I hope that's
so helpful. Thank you.
Sure. Secondary targets in DBT, again, this is pretty much a summary of what's happening in stage 2 DBT. So, this is the question, does DBT treat PTSD? So Melanie, again, a study was done by Melanie Harded in 2008. So after 1 year of DBT treatment, 13% of clients showed remission of PTSD symptoms. After 1 year follow-up, 35% showed remission. Her conclusion was there is room for improvement. So this is doing DBT without doing prolonged exposure or another evidence-based treatment for PTSD. So again, I think I've stressed this. Melanie Harned developed the DBT protocol because while DBT treatment encourages the use of exposure-based treatments for PTSD, it really does not do a great job in specifically describing how or under what circumstances to implement a PTSD treatment. Marsha Linehan in 1993 wrote, I believe that the resulting havoc in the patient's life and the suicide risk are such that the treatment of post-traumatic stress disorder has to be very carefully timed. Part 2 of our webinar, we're going to review, we're going to talk more about what prolonged exposure is and also talk about other evidence-based treatments for PTSD, why Melanie particularly picked this protocol to integrate within DBT, and also when and how to start the DBT protocol. I put this, oh right, I love this slide, and I thought I wanted to make sure everybody has a copy of the Guest House poem, and I think please read this, and it's a poem that I try to read regularly because I think it really highlights the different phases of working with clients and how, you know, it talks about, you know, it teaches clients how they can accept and be present with their emotions no matter how painful they are. And that's what I believe DBT PTSD treatment is all about.
You guys stuck with us, so I will tell you what the bamboo stands for. The reason we chose bamboo to represent me is there's a story about Chinese bamboo, and basically it is if you plant Chinese bamboo, you'll water it, you nurture it, fertilize it the first year, and nothing happens. And then the second year, you water it again, you fertilize it, and there's no growth. You can't see anything. Third year, same thing. Fourth year, same thing. So you're watering and you're fertilizing and still nothing is happening. Fifth year, same thing. Until sometime during the fifth year, all of a sudden in the span of only about 5 or so weeks, the bamboo shoots up high about 80 feet in 5 weeks. And this was after 5 years of nothing. And this is really, I think, a great, great picture of recovery from many things, and for me especially PTSD. My treatment took a while, just like my eating disorder treatment did. And many times along the way, I would tell my therapist, I would tell people like you, Andy, like I would say, I'm not getting better, this isn't working. But the truth is, like everything I was doing something. It was building a foundation. And that bamboo could not shoot up 80 feet in the air if it hadn't been growing for 5 years underground to build roots to support itself for that kind of tremendous growth. And so I really believe that is the case for PTSD treatment. That was what I experienced. I did eventually have this tremendous growth, and like you said, Andy, I got to get to that the last part you talked about with DBT, about the joy, building joy into your life, and that's been the most incredible piece of the treatment. And so I just want to thank you, Andy, for what you do. You devote yourself and help our patients every single day. And I want to thank all of you guys again for listening. And I want to remind you guys also that this is a series, so this was just part 1. And the next series, we're going to bring our colleague on. It's actually going to be Laura Schuster Eflin and me, and I'm Jenny, if you don't know who I am by now. We're going to be talking, and then Andy is going to join us for the 3rd series, but Laura's really going to go over the 3 stages of the DBTP protocol, so please come back. But right now, we actually want to open it up for questions. It looks like we have some, so I think, Andy, some of these were coming in while we were speaking.
Oh, okay.
Supporting a person who has restrictive bulimia cycle developing over past year that was triggered by multiple complex traumas that have become clinically diagnosed as PTSD, and also has many comorbids that have emerged, like perfectionism, OCD, social anxiety, depression, etc. She has a photographic memory, which is great for perfectionism with academics and horrible for trauma work. And that's complicating any therapeutic trauma processing, as she can't seem to decrease her SUD and increase the, I don't even know what that stands for, VOC scores. What is that, Andy? Through EMDR, she reports too vivid and unchanging. Is how you addressed PTSD and ED jointly without effective EMDR?
My question is, how do you address the PTSD and eating disorder jointly without effective EMDR? I'm thinking the question is, do you need to use EMDR? Can you use a different evidence-based treatment? I'm not
something to bring up, like what we talked about last week about how, Marsha Linehan wasn't necessarily, she didn't say what kind of PTSD treatment to use. I mean, it was Melanie Harned that decided to use PE, but isn't it true that Marsha Linehan actually says, you can use any exposure-based evidence-based treatment like EMDR or cognitive processing therapy or PE, prolonged exposure?
Yeah, I think that's the question, and so I would say, and it may also be that, within a DBT lens, I'm just thinking that I don't know if there's a higher, you don't want to treat the PTSD until it's like the highest priority target, and I'm just wondering if there's any suicidality, or if there are any behaviors that accompany the depression that falls under the life-threatening or therapy interfering behaviors. The timing of doing the EMDR might be important.
And I think I got further. She actually commented further on the question to clarify, Andy. Like, it seems like the photographic memory seems to be the biggest stumbling block. Have you ever had a patient with photographic memory and done an exposure-based kind of treatment for PTSD? That's definitely a question out of my league. I'm going to pass it to you.
I haven't. All I can think about is I haven't. This seems like a very complicated case. I'm just thinking about with doing prolonged exposure, that prolonged exposure may lend itself well to somebody with a photographic memory, since what we're asking them through imaginal exposure is to, tell their narrative with every detail they can possibly remember, with every feeling, with every sensation, with every thought. And, the therapist is seeking that information out and asking the patient as they're retelling their story. I don't know enough about EMDR to speak more about this.
I'm going to move on to the next questions. Can you give an example of how to work on PTSD symptoms in stage 1?
Sure. Those of you that possibly do behavior change with your clients, and let's say they engaged in their target behavior, which is drinking, we could potentially, if we're going to behavior chain the drinking, we can link it back on a chain of that they dissociated to a trauma trigger in their environment. So we're working on the dissociation in stage 1. We're going to intervene on the behavior chain. We're going to work on potentially ensuring that, let's say that they are careful and that they don't go to too many environments where there are trauma triggers if they're not feeling safe to be in that environment. And at the same time, we also want to expose them to trauma triggers. So it's a delicate balance. And what I want to say about dissociation, the DBT views dissociation as, oftentimes clients actually have capacity to recognize the early signs of dissociation and can use skills to stay present so that they don't dissociate. So that, I guess, would be an example. And also, like, exposing themselves to feeling shame. So exposing themselves to feeling emotions that accompany PTSD, like shame, fear, working on radical acceptance, accepting the fact that this happened. Should I go on to the next question?
Yeah, and we've kind of touched on this, but yeah, please, Andy, like share what you know on it.
So yeah, I would definitely say while Melanie Harned, of course, picked prolonged exposure because, according to her and other researchers, it's the most research-based program for PTSD, most empirically based, I should say. That other exposure protocols like EMDR, like cognitive processing theory, and I'm forgetting there's one more. Anyway, those fit within the DBT stages of change. So you can even do informal based exposure work in stage 2 DBT. So that's how I would answer that question. Can you give an example of distress tolerance skills? So that's interesting. So Jenny, maybe you could speak about the skills that you learned afterwards that would have helped you specifically. Am I putting you on the spot too much?
Why don't you? Why don't you give examples, and then I can give examples from that. Sometimes I don't always learn when I learn skills from therapists, like they don't usually teach me like this falls into distress tolerance or this falls into mindfulness. Does that make sense? So
yeah.
And then I can go, oh, like I know what you mean. So yes, please take it away.
Sure. And distress tolerance skills. This may be review for many of you. There's two types. There are skills to use when you're in a crisis, and there are skills to use when you need to be able to accept your reality, your past, your present. So in terms of the crisis, the distress tolerance skills, so we teach clients, the stop skill. Essentially, teaching them how to stop, take a step back, observe, proceed mindfully. So this is where we're teaching them how to urge surf, how to...
Yes, I did learn that.
Oh, you did?
I learned urge surfing. Yeah, but go ahead, yeah. I forgot that would be distress tolerance.
Okay, yeah. We teach pros and cons. This is not necessarily a skill to do in the moment when you're in a crisis, but, what are the pros of engaging in your target behavior and what are the cons? What are the pros of resisting the urge to engage in your target behavior? What are the cons of resisting the urge to engage in your target behavior? So a lot of times clients they think, oh, this is going to be so obvious, but if you really take time to do a pros and cons of engaging in target behavior, there's a lot of insight therapists and clients can gain. The tip skills, these are probably the ones that clients gravitate to the most when they're feeling that, they're beginning to dissociate, they're beginning to have a panic attack, feeling like they're in a crisis, change their body chemistry, putting cold water on their face, intensive exercise. Now, this intense exercise may not be the best skill to teach to clients working on eating disorder recovery, paced breathing, those types of things, paired muscle relaxation. And then, of course, the skills that are practicing radical acceptance, these are skills to use not when you're in a crisis, but when you cannot keep painful events and emotions from coming your way. So we teach radical acceptance. We could spend 3 hours just talking about radical acceptance. Half smiling, willing hands. Jenny, did you learn how to do that?
I did learn half smiling, yes. Someone was asking if I could speak more about my PTSD symptoms and how it became clear that PTSD was an issue from birth trauma. So I probably should clarify that a little more with my story. So I believe my PTSD that developed fully when I got married was really a result of the rape by my ex-boyfriend in my 20s. I believe that the fact that I had prior birth trauma, 27 years before that, actually possibly made me more vulnerable to developing PTSD later. So I personally don't think my PTSD was a direct result of my birth trauma, but I think the birth trauma might have helped load the gun, if that makes sense. So just kind of the more traumas you put into someone's life makes them more vulnerable to PTSD. There's even some studies, we need more research, that might show that birth trauma could make someone more vulnerable to anorexia nervosa as well, but that's a whole other webinar. But as far as the PTSD symptoms, how I became clear with PTSD, that is such a great question. And this is where we talked last week. I feel like a lot of us, and me too, we get kind of stuck in our fields. Like when I was only talking about eating disorders, I kind of saw everything as like everything was an eating disorder to me. But now my lens is wider. It's like, oh, I know what PTSD is now. But so I think for me, I was seeing a lot of providers just for eating disorders, so we kind of had this lens on where everything we were looking at, it's like it has to be an eating disorder. This all has to be related to eating disorder. But when my PTSD started showing up, which really started showing up initially as startle response, and this, I would jump, it kind of looked like this. It was like, it's like if someone came up behind me and scared you, if someone walked into your room right now and scared you and you would go like that, that's kind of what my first symptom of PTSD was, that I could actually see something that seemed really weird and different. And so that exaggerated startle response was the whole reason I even discovered I had PTSD, because again, like the article in the beginning says, is I had this startle response. And when I started dating my husband, as an example, he would pick me up on dates, and as soon as I saw his car pull into the driveway, my body would start startling and shaking and, just really fearful. And so that was kind of the symptom that for me led to the diagnosis, which for me a diagnosis just points to hope, and it points to the fact that you're not alone. So for me that was really helpful to finally get a diagnosis, but I know some patients, feel differently on that. But that's a great question, and thanks for letting me clarify that. And then someone else was asking, what is important to work on first with an adult client when an adult client is grieving the death of a parent, grieving the loss of the other parent due to Alzheimer's, as well as PTSD, anorexia, depression, and anxiety? Wow, that's so sad. Andy, do you want to take that? That's a complex patient for sure.
Yeah, and I think for me, since I use DBT, I would fall back on the DBT stages and look at, are there look at the life-threatening behaviors, the therapy-interfering behaviors, start with that. So again, it depends on how severe their depression is and anxiety. In terms of treating the PTSD directly, you only want to treat that when it's the highest priority target, or, again, like looking at those stages. And again, I don't know if the PTSD is related to the loss of the parent. So if the PTSD is related to those losses, I guess that would be a question I'd have as well. Not related. Right. So, okay. So it's I'm looking at sexual abuse. Again, I would really go back to the stages and see what's interfering the most, and really ask the client what's interfering the most. Obviously, with anorexia, I would imagine it also is, how severe the anorexia is, how compromised their functioning is. This is a really tough one. I'm curious where you're starting. And I think a lot of this also depends on, what level of care, if she there, an outpatient level of care, higher level of care. And I think just important to keep in mind, like within a DBT lens, we are treating the symptoms of PTSD. We are treating the associated consequences and how PTSD is impacting the individual, yet we're not necessarily targeting the processing, the narrative piece until stage 2. So you can be treating multiple targets at the same time because, again, it's all connected.
And she said grief has been the difficult. Yeah.
To me, that would be, a quality of life, probably interfering behavior that would need to take priority. before starting more focused PTSD treatment. And I do want to stress, how I'm talking about treating PTSD again. We have clients that, Jenny, do you remember the statistic from our director of research around, more of our clients?
Yeah, well, what we found at our mood and anxiety program, which is Insight Behavioral Health Center. So for those of you who are familiar with Eating Recovery Center, I should probably explain that first. So Eating Recovery Center is in partnership with Insight Behavioral Health. So Andy, who you've been listening to, is the director of the mood anxiety program, which is Insight. So our patients at Insight, they don't have necessarily eating disorders, where our patients obviously at ERC, Eating Recovery Center, have eating disorders. But so our patients at Insight really come in with mood anxiety problems. And so what Keegan found is that who does our research, he found that about 80% of our patients come in with PTSD, DSM-5 PTSD symptom level criteria. Basically, almost 80% of our patients at Insight, they meet the criteria for post-traumatic stress disorder when it comes to the symptoms. They meet all the criteria for the symptoms. The only reason some of the patients don't get the diagnosis of PTSD is that their trauma it's not good enough according to the DSM-5. So you guys know DSM-5 says for you to have a trauma, it has to be A, B, C, D, E, F, G. And so some of our patients, they don't get the PTSD diagnosis just because their trauma, according to DSM-5, doesn't qualify. And that is kind of annoying to me, that DSM-5 labels trauma. So stay tuned. I'm writing a book about PTSD, and I'm going to write about how I don't think DSM-5 should tell us whether our trauma is valid. But that's a whole other talk, too. But, yeah, so that's kind of what the research shows. So really, I mean, Andy, you're seeing every day, I mean, it seems like 80% of our patients have PTSD symptoms. And is that what you would, is that how you feel? I mean, you obviously, that's what, you're there every day.
Yes, I definitely feel that way. Very much so.
And it's Keegan Walden, too. I should give him a shout-out. He's our director of research. So this webinar hits home. I mean, we see so much PTSD. So how do you help support a client that is not choosing to make the commitment to use the skills despite choosing to be in overall treatment?
Oh, boy, yes.
That's a good one.
That's a really good question.
Great question.
Jenny, I know from a therapist, but as a client, did you ever feel that way?
Oh, yeah, I mean, for sure. I mean, I think it goes back to the reason I wrote down that quote you said that somebody else really liked was commitment is a choice, choosing is a behavior. So, I mean, for me, I think part of it was I didn't think I had the ability to make a commitment to use skills. Like, to me, I felt like PTSD hijacked my brain. So anything I'm doing, it's not my fault. PTSD's, like, my amygdala is basically driving the bus here. I can't do anything about it. So what I really needed was my treatment team to empower me and say, actually, you still are driving the bus. In fact, we incorporated ACT too, acceptance commitment therapy, which I know has the bus metaphor. But so a lot of my treatment involved my treatment team really saying, like, no, you can make this choice to commit. You can do this. I know you feel like you can't because you have these PTSD glasses on and everything's blurred and you're not seeing right. The world looks like it's out to get you, but trust me, like, we've seen it work before. You can do this. I mean, my treatment team really held on to hope when I completely lost it. So really just the empowering the patient. That was what helped me a lot. It was when my treatment team would say, no, actually you can do it, and yes, you have PTSD, and you can also use skills, and you can also, you can do better. But how would you answer that?
Yeah. No, thank you, Jenny, for that. I think I would really work with them on the skill of willingness, which is in the distress tolerance section. Really work on their willfulness with them. And I don't know if you use the diary card, what I do with clients that are not using their skills. Before we talk about anything else, I'm going to be asking them for us to look at their diary card for the week, and that's a whole other story. If you want to learn about the diary card, just email me. I'm happy to talk to you about that and teach you about it. And we won't process until they can behavior chain why they chose not to use skills in that moment they engaged in their target behavior. It's not fun, yet I do think that clients, deep down really appreciate it and really appreciate being gently confronted about their willfulness and teaching them about willfulness and teaching them that we don't judge their willfulness. They're likely judging their willfulness. We are just acknowledging it. It's just a fact. And what are the barriers to using your skills? And really just focus on that. Sometimes we have to step a patient down a level of care if, like, I can identify with they're choosing to be in treatment, but they're not really doing treatment, right? So again, like, recovery is a choice, treatment is a choice, it's doing it. I hope that helped a little bit.
So maybe we should move to the last question. Can you speak more about prolonged exposure? Yeah, so in prolonged exposure, there's the imaginal types of exposure, or what they call in vivo exposures, which are like in real life exposure. So for my imaginal exposure, actually when I went through PE, my treatment teams had me write out a trauma script, like actually write it. And that's not necessarily a part of the actual prolonged exposure therapy, but we did write the trauma script. And the trauma script itself, the narrative, is absolutely a part of prolonged exposure. But so for me, I started off by writing a trauma script. And the first time I tried to read it in therapy, I actually hyperventilated and had a panic attack. And it was an interesting thing because my therapist said, he actually was kind of excited about that. And he said, well, this is great. We know we found the trauma because you're reacting, like you've activated the fear structure, EDNAFOA, prolonged exposure therapy might say. So he would say, this is the trauma. If you're hyperventilating and you're having a panic attack over this piece of paper, this trauma that you're about to talk about, which was the sexual trauma with my ex-boyfriend, he said, then this is the trauma we need to work on, and he was right. And so I went from hyperventilating with a piece of paper to actually being able, with imaginal exposures, to go through my trauma script, say it out loud over and over and over again in therapy, record it on my iPhone, and listen to it as homework. So that was kind of the imaginal piece of it. So constantly I was listening to the trauma scripts on my phone, which might sound really barbaric in some ways. In fact, some people say PE sounds cruel and unusual punishment, but for me it actually wasn't. Listening to the trauma script actually felt like it was kind of putting my brain back in the right place again. So I even have a journal entry where I wrote, listening to my trauma script over and over again actually helps it makes my brain get back online. So no longer is my amygdala running the show. It's like just listening to that script kind of clicks it all back to where it needs to be. And so interestingly enough, in my PHP program, all of us in group, if we were struggling and having a hard time, we would actually say, you know what I need to do tonight? I need to go home and listen to my trauma script, because we knew it would help us, which was so interesting, right? I mean, it's like we were saying, we'll go home and take a bubble bath. I mean, so that was just a piece of my kind of the imaginal exposures. And for me, in real life, the in vivo exposures, they're all going to be different for different people, right? So someone had a car accident, they're going to eventually get in a car and drive. For me, I was scared of intimacy, of relationships. So one of my assignments, I laugh now because it's funny to me now, but I used to get women's magazines in my mail at home because I sometimes write for them, like articles about eating disorders, body image. So I would get these magazines, not necessarily to read them because I was scared of them, because the cover would all talk about intimacy and relationships and love. And so I would see these magazines in my mailbox, and I would treat it as if it was like a roach or a snake, and kind of pick it up and just throw it into the corner and never touch it again. I was literally scared of magazines, which can't hurt me. So part of my exposure in real life was I had to sit in a room and just go through women's magazines, just reading them over and over and over again until I stopped startling. So that's just a little example. And that actually was so helpful to me. So in a sense, women's magazines helped me recover from PTSD. And that wouldn't be the case for, someone in a car wreck or another kind of trauma, but that was just specific to mine. So yeah, but do you have anything to add, Andy, and about that?
I think that, just in terms, no, Jenny, I mean, these are really helpful examples. And, with prolonged exposure, we work with a client on both the imaginal, the retelling of the story, their narrative, and also in vivo exposures or, real life exposures, helping them exposing themselves to trauma triggers or things that they have avoided due to their trauma. And like you said, prolonged exposure, the heart of it is having the client listen to their story because they record it over and over and over again. And while they're telling the story, the DBT added this, but also prolonged exposure evaluates not only are their SUDs going down, but what is their level of depression, shame, fear, guilt, and I think the other emotion is radical acceptance, which I guess isn't an emotion, but it's it's an experience. So there's a lot to PE, which I'm really excited for our next webinar. Talk about that.
Yeah, and I know we need to close. And I should say, we've thrown an acronym out there a couple of times that maybe some people don't know. So SUDS is Subjective Units of Distress. So when I was hyperventilating, my SUDS was really high. But now I can listen to my trauma script. I mean, I don't even have to anymore. I never do anymore. But it's neutral. It doesn't have – it's a memory that happened in the past, and it's now filed away in its correct folder, if that makes sense. So, but we'll talk about that more next time. Please sign up for our – Part 2 and Part 3 when Andy will be back. So next time it's Laura and me, and then third time it's Andy. It'll be all three of us. But make sure you guys remember to stay logged on after the presentation, and it's really important that you stay logged on and answer the questions so that you'll get your CE certificate and credits. And we just want to thank you again for joining, and please tune in, and if you have any other questions, you can type it in, and we'll email you back answers. But thanks, Andy, for doing this with me.
Thank you, Jenny.
Eating Recovery Center's mission is to provide the very best care to patients, families, and providers of care in the treatment of and recovery from eating disorders and related conditions.